All right, let's unpack this. We were starting today with a document from June 5, 1981.
Right.
And it is, I mean, if you weren't looking closely, you would have totally missed it. It's this tiny, seemingly unremarkable two-page item.
Yeah, just tucked away.
Exactly. It was printed by the Centers for Disease Control in a publication called the Morbidity and Mortality Weekly Report.
The MMWR, yeah.
Right. And it just detailed the medical cases of 5 young, previously healthy men in Los Angeles who had suddenly come down with this really rare, incredibly aggressive form of pneumonia.
Which, nobody knew it at the time, but
Right. But those 2 pages were literally the opening sentences to a crisis that would just completely define the late 20th century. I mean, they had just printed the first official federal notice of what would eventually become the AIDS epidemic.
yeah. And, looking back at that document now with all the decades of hindsight we have, it's just chilling.
Oh, wow.
Because you are basically reading the exact moment when the timeline of human health just permanently fractured.
Wow.
I mean, everything before June 5, 1981 belongs to one specific era of medicine, and everything after that belongs to an entirely different one.
It really does. And when I was looking through our stack of sources for this deep dive today, the historical timelines, the archival records, the clinical notes from the 80s, I kept thinking, this story isn't just some history lesson.
No, not at all.
It's the blueprint for literally everything we do in medicine today. It completely reshaped American public health.
Yeah.
But as you dig into the history, you start to realize the government's response wasn't this unified, heroic effort. It was a completely split screen, wasn't it?
Yeah, that is, if we connect this to the bigger picture, that is the core thesis of what we are looking at today. The HIV/AIDS epidemic is really the moment the federal health role cleanly split in two.
Right.
Because on one side of that screen, you see the government machinery functioning exactly as it was designed to. You see surveillance systems catching the anomaly.
The MMWR report.
Exactly. And later you see the extraordinary use of the moral pulpit to educate the public. But then on the other side of that same screen, you see this agonizing, crushing official silence.
Yeah, just devastating.
You see terrifying mortality rates just climbing year after year while the federal apparatus completely drags its feet.
Right.
And what becomes undeniably clear from the sources is that the actual cures, the prevention strategies, the urgency itself, all of that had to be dragged into existence by outside forces.
It wasn't coming from the top down.
No, it was forced by academic labs, pharmaceutical science, and, above all, by furious, brilliant patient activists.
And for you listening, whether you realize it or not, this history is actively touching your life right now. I mean, the way the FDA approves the drugs sitting in your medicine cabinet right now, or the way you are allowed to advocate for yourself in a clinical trial, and even the massive international tools we use to stop global pandemics today, every single one of those systems was forged in the fire of the events we're about to discuss.
It's so true.
This is a deep dive into how a universally fatal unnamed terror became a manageable condition, and how the fight to get there just rewrote the rules of medicine forever.
It really is a profound paradigm shift. And, to understand how much the paradigm had to change, we really have to start at the very beginning, back with that June 1981 MMWR report.
Right, so let's get into that. What exactly is the MMWR?
So for anyone working in public health, the MMWR is essentially the central nervous system's daily dispatch.
Okay.
It's the primary mechanism the CDC uses to flag anomalies across the country.
Right, it's like a data gathering net. And in the specific report, they flagged something called pneumocystis pneumonia.
Yes.
So can you explain why that specific diagnosis in just 5 young men in LA? Why did that set off such massive alarm bells for the epidemiologists who were reading it?
Well, basically because it made absolutely no biological sense.
Really? Why not?
Because pneumocystis pneumonia is what we call an opportunistic infection. It's caused by a fungus, Pneumocystis jirovecii, which is it's ubiquitous. It's everywhere.
Like we breathe it every day.
Yeah, you and I are probably breathing it in right now. But a healthy human immune system just swats it away effortlessly. You'd never even know you encountered it.
Okay.
It only causes pneumonia if the host's immune system has completely catastrophically collapsed.
Oh, wow.
Historically, before 1981, you would only really see this in patients whose immune systems were intentionally suppressed, like organ transplant recipients.
Right, where they have to take drugs to suppress rejection.
Exactly. Or perhaps in patients in the very late stages of severe starvation or severe cancer.
So to see it in 5 guys in their 20s and 30s who are otherwise perfectly healthy.
Yeah.
And they're all living in the exact same city, all belonging to the exact same demographic.
It was a glaring neon red flag. It meant that some completely unknown agent was mysteriously erasing their immune systems.
That is terrifying.
It is, but it also shows that the public health surveillance system did exactly, flawlessly, what it was designed to do.
Right, it caught it.
Epidemic intelligence is fundamentally about watching the horizon, spotting the anomaly, and writing it down.
Yeah.
And the CDC saw the pattern immediately. They documented it. The surveillance succeeded.
But the response to that surveillance, I mean, going through the historical record for this deep dive, I just keep coming back to this analogy.
Okay, let's hear it.
It's like having the world's most advanced, incredibly sensitive fire alarm system, right?
Right.
And it correctly detects smoke in the basement. It identifies the exact chemical composition of the smoke. It prints out a perfect, peer-reviewed report stating that, yes, there is absolutely a fire.
Yeah.
But then the fire department simply decides not to roll out the trucks. They just let it burn.
Wow. That is a brutally accurate way to describe the dynamic of the early 1980s, because the scientific and medical recognition of the disease moves so much faster than the institutional response.
Right.
I mean, within a year of that initial 1981 report, the syndrome had a name: AIDS, or acquired immunodeficiency syndrome.
They figured out the basics pretty quickly, didn't they?
They did. The medical community quickly figured out its terrifying epidemiological profile.
Oh.
They knew it was sexually transmitted and bloodborne.
Okay.
They knew it was destroying the cellular immunity of its victims.
Right.
And they knew it was uniformly, brutally fatal.
Okay.
But the mobilization of federal resources to actually fight it, to research it, to care for the dying, that lagged terribly, tragically behind.
And the human toll described in these early sources is just staggering.
It really is.
We are talking about the early to mid-1980s here. This wasn't just a fatal disease, it was a highly stigmatized one.
Right.
It was striking marginalized groups. Initially, gay men, intravenous drug users, and eventually hemophiliacs who relied on the national blood supply.
Yeah.
And as the death toll climbed, I mean, month after month, there was this agonizing, deafening silence from the top levels of the federal government.
Yeah, and to truly grasp the gravity of that era, you have to look at it through the eyes of the medical professionals who are suddenly standing on the front lines of this unnamed plague.
Absolutely.
In our sources, we have these clinical accounts from physicians, like Nick, a doctor whose notes helped compile this history. He was doing his medical training during this exact window.
That must have been, I can't even imagine.
Imagine being a young doctor in New York or San Francisco in, say, 1982 or 1983. You are walking into hospital wards that are just overflowing with young men in their 20s and 30s.
Right.
They're wasting away. They're covered in the purple skin lesions of Kaposi sarcoma, which is another opportunistic disease. They are suffocating from pneumonia.
And as a doctor, you literally have nothing to offer them. No cure, no treatment, no hope, just nothing.
Exactly. For a whole generation of clinicians, this was a defining, lifelong professional trauma.
I bet.
There were healers who could not heal. They were forced to essentially run hospices for the young, helplessly watching a uniformly fatal disease unfold, while the broader society and the political establishment largely just looked away.
Which brings up a point we need to be incredibly clear about here.
Yeah, go ahead.
Looking strictly at the historical consensus documented across all our sources, and to be clear, we are not taking political sides here. We're just objectively reporting what the historical records state.
Right, the documented reality.
Exactly. The federal administration's response at the time in terms of urgency, funding, and public acknowledgement has been widely, credibly recorded by historians and public health experts as devastatingly slow.
Yes.
The documented reality is that this sluggishness was deeply intertwined with the fact that the disease first struck heavily stigmatized, marginalized groups. That isn't a political opinion. That is the documented historical reality of the early 1980s.
Yeah, it was a terrifying biological crisis, compounded by a profound systemic failure to act.
The complete failure.
But that systemic failure created a massive vacuum, because if the political will wasn't there to fight the disease, the scientific imperative certainly was.
Right, because the doctors and scientists are still trying to solve it.
Exactly. In the laboratories, there was this frantic, desperate race to pin down the biological cause of this immune collapse. Up until 1983, AIDS was just a syndrome. The S in AIDS literally stands for syndrome.
Just a collection of symptoms.
Right. Doctors knew what the disease did, but they didn't know what the disease actually was.
You can't fight an enemy you can't see. So how do we actually transition from the clinical terror of these hospital wards to the microscopes? How do the scientists finally pinpoint the killer?
Well, the breakthrough came when researchers finally isolated the infectious agent and identified it as a retrovirus, which would eventually be named HIV, the human immunodeficiency virus.
Okay, let me stop you there because the term retrovirus gets thrown around a lot.
Sure.
How is a retrovirus mechanically different from, say, a standard virus like the flu or a common cold? Why is it so uniquely insidious?
That is the critical question. To understand why HIV was so incredibly hard to cure, you have to understand its mechanics.
Break it down for us.
Okay, so most standard viruses work like a hostile takeover of a factory. They enter a cell, they bring their own blueprints, they force the cell's machinery to manufacture thousands of copies of the virus, and then the cell bursts open and dies, releasing the new viruses.
Okay, standard biological hijacking.
Right. But a retrovirus does something far more elegant and far more sinister.
How so?
It utilizes an enzyme called reverse transcriptase.
Reverse transcriptase, okay.
Normally in biology, the flow of genetic information goes from DNA to RNA to protein. DNA is the master blueprint stored in the vault, right? And RNA is like the photocopy sent down to the factory floor.
Makes sense.
But a retrovirus brings its own RNA and reverse transcribes it backward into DNA.
Whoa.
It then takes that newly minted viral DNA, enters the nucleus of the human cell, and literally splices its own code into the host's master blueprint.
Wait, really? It changes the vault?
It writes itself permanently into the patient's own genetic code.
So it's not just taking over the factory floor. It's sneaking into the corporate vault and rewriting the foundational blueprints of the entire company.
Precisely. And the cell doesn't even know it's been hijacked. It thinks the viral DNA is its own.
That is wild.
And to make it even more diabolical, HIV specifically targets and infects CD4 T cells.
Which are what, exactly?
These are the specific white blood cells that act as the generals of the human immune system. They are the exact cells responsible for coordinating the body's defense against invaders.
Oh my God.
So HIV doesn't just evade the police, it specifically targets the police stations, turns the police officers into virus manufacturing plants, and then destroys them.
It dismantles the very system designed to eliminate it.
Exactly.
That is terrifyingly efficient biology. But reading through the history of how this virus was discovered, it wasn't exactly a peaceful, collaborative triumph of human ingenuity, was it?
No, not at all.
We're talking about a bitter, incredibly intense dispute over credit that broke out in 1983 and 1984.
Yeah, a massive fight.
On one side, you have the Pasteur Institute in France, led by scientists Luc Montagnier and Françoise Barré-Sinoussi. And then on the other side, you have the U.S. National Cancer Institute, led by Dr. Robert Gallo. What exactly happened here? How do scientists get into a turf war while a plague is actively raging?
What's fascinating here, and honestly deeply frustrating, is how human ego, national pride, and massive financial stakes shadowed pure scientific discovery.
Right.
Both of these laboratories were doing absolutely groundbreaking world-class virology. The timeline essentially shows that the French team at the Pasteur Institute isolated the virus first, and they originally called it LAV.
Okay.
But Gallo's team, the U.S. National Cancer Institute, who had extensive experience with retroviruses, provided crucial confirmation.
What did they do?
Gallo's lab figured out how to grow the virus in continuous cell lines, which is incredibly difficult to do, and they firmly proved that it was the definitive cause of AIDS, calling their virus HTLV3.
But instead of, pooling their resources and celebrating a shared victory, they ended up in a massive legal and public relations fight over who technically discovered it first.
Yeah, they did.
And it wasn't just about pride, right? There were massive patent implications.
Exactly. The discovery of the virus was the necessary prerequisite for developing a blood test to detect it.
Ah, of course. The blood test.
Whoever held the patent for the discovery would hold the patent for the test. So you had international lawyers arguing over patent rights and royalties while patients were actively dying in the wards.
That is just, it's a really dark chapter in scientific collaboration.
It was.
Yeah.
Ultimately, the governments of the U.S. and France literally had to step in and broker an international agreement to share the credit and the royalties.
Just to wrap up the historical scorecard on that, the sources note that while both teams undeniably laid the foundational science, the ultimate historical verdict came decades later. The 2008 Nobel Prize in Medicine was awarded solely to the French scientists Barré-Sinoussi and Montagnier for the discovery of HIV. But regardless of the courtroom drama, identifying the virus was the real turning point. Because once you know what the virus is and you can grow it in a lab, you can finally build a test for it.
Exactly.
Which leads us to 1985, and the very first practical systemic tool against the epidemic, the HIV antibody test.
This was a monumental shift in public health. You have to remember the biological reality of HIV. It has a very long clinical latency period.
Meaning you don't look sick.
Right. A person can be infected, feel completely healthy, have zero symptoms, and yet be highly contagious for years.
Wow.
Before 1985, this made the national blood supply incredibly vulnerable. People were going into the hospital for a routine surgery or a blood transfusion, or they were hemophiliacs requiring regular clotting factors, and they were unwittingly contracting HIV.
Because the blood banks had absolutely no way of knowing if the blood they were collecting was infected, they were flying completely blind.
Exactly. The licensure of the 1985 blood test changed that overnight. Now, crucially, it was an antibody test, not a test for the virus itself.
What's the difference?
It tested whether the host's immune system had generated antibodies in response to the virus, rather than spotting the actual virus particles. But it worked.
It did what they needed it to do.
Yes, it finally allowed the widespread screening of the blood supply. It didn't offer a cure for those who were already sick, but it slammed the door shut on a massive institutional vector of transmission. It was the crucial first step in systemic prevention.
Okay, so let's look at the board in 1985. The CDC surveillance has identified the epidemic.
Yep.
The academic labs have identified the virus. The scientists have secured the blood supply. But if you look at the top levels of the federal government, there is still this crushing, pervasive silence regarding public education.
Oh, absolutely.
The administration is still treating this disease as an untouchable, taboo subject. Which brings us to perhaps the most fascinating, unlikely hero in this entire timeline. It's 1986. Enter Surgeon General C. Everett Koop.
Koop is such a complex and vital historical figure.
He really is.
When he was appointed by the administration, he was a famous pediatric surgeon, but he was also known as a staunch, outspoken, conservative evangelical.
Right.
His background, his previous writings, his entire public persona strongly suggested that he would align perfectly with the administration's moralistic approach to the epidemic.
Which was basically to preach sexual abstinence, avoid talking about intravenous drug use, and otherwise keep the federal government out of the messy business of explicit public health education.
Yeah, they fully expected him to be a loyal, quiet soldier.
Here's where it gets really interesting, though.
Yeah.
Because he didn't do that. Koop was, first and foremost, a doctor.
Right.
He looked at the epidemiological data, he looked at the skyrocketing death toll, and he made a profound ethical calculation. He concluded that as the nation's top doctor, scientific reality and brutal honesty were the only acceptable courses of action for public health.
Yes. He refused to let his personal religious ideology or the political sensitivities of his bosses dictate his response to a lethal pathogen.
And what he does next is just incredible. In 1986, he issues the Surgeon General's report on AIDS. And I really want to emphasize how shocking this document was at the time.
It was explosive.
He didn't use coded, polite political language. He spoke explicitly about sexual transmission. He spoke openly about the risks of intravenous drug use and sharing needles. And crucially, he explicitly advocated for the use of condoms as a primary prevention method.
Yeah.
It was a seismic shock to the political establishment because it was the federal government, finally, speaking clearly and accurately about the biological reality of the disease.
He essentially broke the embargo on truth. And then he takes it a massive step further.
Right, in 1988?
In 1988, he oversees the creation of a public health brochure called Understanding AIDS. It was designed to translate the complex virology and epidemiology into plain, direct English that anyone could understand.
No medical jargon.
Exactly. It dismantled the myths about how the disease spread, clarifying that you couldn't get it from a toilet seat or a mosquito bite, and reiterated how to protect yourself.
But he didn't just print it and leave a stack of them in local libraries or clinics, did he?
No, he didn't.
He utilized the full logistical weight of the federal government to mandate that this plain-spoken, explicit brochure be mailed to every single residential address in the United States.
Every single one.
Every home, every apartment. We're talking about roughly 107 million households. To this day, it remains the largest public health mailing ever attempted in human history.
Think about the pure logistics of that, let alone the intense political pushback, the internal administration fights he must have endured to get that funded, approved, and handed over to the Postal Service.
But wait, this brings up a really interesting structural question.
Yeah.
If you look at the actual organizational chart of the U.S. government, the Surgeon General doesn't really have executive power, right?
Right, not really.
He doesn't command the massive research budgets of the NIH. He doesn't run the FDA. He can't dictate federal legislation. So how does a guy who essentially just has a desk, a title, and a fancy uniform bend the trajectory of a global epidemic just by sending out mail?
Because Koop understood exactly what the power of the modern Surgeon General actually is. It is not executive power. It is entirely moral power.
Ah.
He possessed the bully pulpit. He had the microphone. He couldn't force a pharmaceutical company to invent a new drug. And he couldn't force Congress to allocate billions of dollars, but he could force the American public to confront the truth.
That is so powerful.
He used his immense moral authority to bypass the political filters, bypass the squeamishness of the administration, and deliver life-saving scientific facts directly into the hands of the people. He filled the vacuum of official silence with rigorous, compassionate truth.
It is the purest illustration of a government official using their pulpit to save lives.
Absolutely.
But here's the harsh reality, Education does not cure the dying.
No, it doesn't.
A brochure in the mail might prevent the next infection, but for the hundreds of thousands of people who are already infected, for the people who are watching their friends and partners wither away in those hospital wards, a brochure wasn't enough.
They needed medicine.
Exactly. They needed molecules. And the federal research and drug approval apparatus was moving at a glacial, paternalistic pace. So starting in 1987, the narrative shifts dramatically.
It does.
The driving force moves from inside the government to the outside. We have to talk about the activists. Above all, ACTUP.
The AIDS Coalition to Unleash Power.
Yes.
This is the pivot point where the entire relationship between patients and the medical establishment is permanently rewritten. To understand what ACTUP accomplished, you have to understand what the paradigm of medical research looked like before they arrived.
Set the scene for us. What was the FDA like in the mid-1980s?
It was incredibly top-down and deeply conservative in a regulatory sense.
Okay.
The system was designed around extreme caution. Following tragedies in the mid-20th century, like the thalidomide disaster, the FDA was mandated to rigorously, exhaustively test drugs for both safety and efficacy.
Which sounds good on paper.
It does. But this meant designing massive, double-blind, placebo-controlled clinical trials. Scientists in ivory towers designed the protocols. The process could take years, sometimes over a decade before a drug reached the market.
10 years.
Easily. And in this system, patients were viewed as entirely passive subjects. You get sick, you go to the doctor, you wait for the medical establishment to hand down a cure, and if they don't have one, you go home and you die quietly.
But the activists of ACTUP, who are largely drawn from the gay community, many of whom were HIV positive themselves, and facing an imminent death sentence, they looked at that paradigm and completely rejected it.
Oh, absolutely.
They turned their profound grief, their terror, and their righteous rage into a highly sophisticated, fiercely targeted pressure campaign. They looked at the traditional 10-year timeline for drug approvals and essentially said, we don't have 10 years. We have 6 months before we die.
Exactly. They refused to die quietly. And what made ACTUP so extraordinarily effective was that their activism wasn't just raw protest. It was highly educated, strategic intervention.
They really did their homework.
They didn't just chant outside the gates of the National Institutes of Health or the FDA. They formed committees, like the Treatment and Data Committee. They went to medical libraries. They taught themselves virology, immunology, and the complex biostatistics of clinical trial design. They learned the jargon of the enemy. They essentially became lay experts in the incredibly dense science of the disease that was killing them.
It's like, imagine you're a passenger on a sinking ship.
Okay.
The traditional expected behavior is that you stand patiently on the deck, trusting the captain, and politely demanding that the crew bring you lifeboats.
Right.
But ACTUP didn't do that. They bypassed the deck entirely. They stormed the engine room. They ripped the ship's blueprints out of the captain's hands. They pointed to the flaw in the hull design. And they demanded that the engineers redesign the buoyancy systems immediately while the water was rising.
That is a perfect analogy, because they realized that the regulatory caution of the FDA, which again was explicitly designed to protect people from unsafe experimental drugs, was ironically killing them.
Because they didn't have time to be safe.
Right. If you have a disease that is 100% fatal, the risk of a toxic side effect from an experimental drug is completely acceptable. A patient facing certain death wants the right to take that risk. ACTUP demanded a seat at the scientific table, and they backed up their demands with massive, highly visible civil disobedience.
Like the massive protest in October 1988, right? When over 1,000 activists essentially laid siege to the FDA headquarters, completely shutting the agency down for a day. They wore lab coats stained with fake blood. They chained themselves to doors. But they also came armed with incredibly specific, scientifically sound regulatory demands.
Yes. They weren't just vaguely demanding a cure. They were demanding very specific regulatory mechanisms.
Like what?
Well, they demanded the creation of fast-track approval processes for life-threatening illnesses. They fought for what became known as the parallel track, which allowed desperately ill patients who didn't qualify for strict clinical trials to still access experimental, unapproved therapies through compassionate use protocols.
That's huge.
And they argued that placebos were unethical in trials for uniformly fatal disease because giving half the patients a sugar pill meant condemning them to death.
And the incredible thing is, they won.
They did.
They completely bent the federal research apparatus to their will. They forced the system to view patients not as passive victims, but as active, vital, indispensable participants in their own survival.
It changed everything.
And for you listening today, this is why this specific chapter of history matters so deeply. If you or a parent or a friend has ever benefited from a fast-tracked experimental medication for severe cancer or Alzheimer's or any life-threatening illness, you are benefiting directly from the regulatory doors that ACTUP battered down in the late 1980s.
They permanently reshaped the institutional relationship between the government, the pharmaceutical industry, and the patient. The daily lives of people living with HIV changed fundamentally because they took agency over their own bodies.
Right.
They fought for their lives in the streets, in the laboratories, and in the regulatory hearing rooms. But as vital and world-changing as that agency was, there is a hard biological limit to activism.
What do you mean?
Well, you can yell at a pharmaceutical company, you can streamline the FDA's pipeline, but the activists themselves couldn't synthesize the molecules. The pressure they applied brilliantly sped up the pipeline, but the pipeline still had to eventually produce a drug that actually worked.
Which brings us to the actual science that turned this epidemic around. Because applying pressure is one thing. What actually comes out of the laboratories is another.
Exactly.
The first major medical milestone to come out of this accelerated pipeline arrived in 1987 with the FDA approval of a drug called AZT, or zidovudine.
AZT was a monumental psychological and historical moment simply because it was the very first antiretroviral drug. It proved, conceptually, that this invincible virus could actually be attacked.
Right.
But looking at the clinical data from the late 80s, we have to severely temper the excitement of that 1987 approval.
Right, because AZT wasn't some miracle drug designed from scratch for HIV, was it? Where did it actually come from?
It was actually a compound that had been developed back in the 1960s as a potential treatment for cancer. It was pulled off the shelf and tested against HIV because of how it functions chemically. AZT is what we call a nucleoside reverse transcriptase inhibitor.
Okay, that's a mouthful. Break down the mechanics of that for me. How does it actually attack the virus?
Think back to our earlier discussion about reverse transcriptase, the enzyme the virus uses to build a DNA copy of itself.
The guy breaking into the vault.
Right. To build that DNA chain, the virus needs raw materials. It needs genetic building blocks, like a bricklayer building a wall.
Yeah.
AZT is essentially a fake defective building block.
All right.
It looks exactly like a normal piece of DNA, so the virus grabs it and adds it to the chain. But because it's defective, no more blocks can be attached to it. The chain terminates, the virus can't finish copying itself, and replication stops.
That is a brilliant chemical trick. You're handing the bricklayer a styrofoam brick, and the whole wall falls apart. So if the mechanism is that clever, why did AZT fail to be the silver bullet?
Two major reasons.
No.
Severe toxicity and rapid viral mutation.
Let's start with toxicity.
First, the toxicity. Because AZT was fundamentally a cancer drug designed to stop cellular replication, it didn't just trick the virus. It also tricked the host's healthy cells, specifically the rapidly dividing cells in the human bone marrow.
Oh, no.
Side effects were absolutely brutal. We're talking about severe, life-threatening anemia, crippling nausea, muscle wasting. Many patients described it as taking a poison that hopefully hurt the virus just slightly more than it hurt them.
That is grim. And the second reason, the mutation, this goes back to the biology of the virus itself, doesn't it?
Yes. HIV replicates at an astonishing, almost unfathomable speed, making millions upon millions of copies of itself every single day. And the enzyme it uses to copy itself is incredibly sloppy.
Floppy.
It makes constant mistakes. It generates mutations constantly. When you treat a patient with AZT alone, what we call monotherapy, a single drug treatment, you are essentially providing an evolutionary training ground for the virus.
It learns how to beat it.
Out of the millions of sloppy copies, one random mutation will naturally alter the shape of the reverse transcriptase enzyme just enough that it stops grabbing the fake AZT building block. Wow. That one resistant virus survives, replicates, and within weeks, the patient's entire viral population is completely resistant to AZT. The drug becomes totally useless.
This raises such a massive biological question. How do you defeat an enemy that constantly, endlessly shifts its shape? If hitting it with one drug just teaches the virus how to evade it, what is the strategy?
That exact question hung heavily over the entire medical community for nearly a decade. From 1987 until the mid-1990s, treating HIV was this agonizing game of clinical whack-a-mole.
Just constantly chasing it.
The labs would invent a new drug, like DDI or DDC. The patients would take it, the virus would mutate around it, and the death toll continued to climb unabated. But then, we hit 1996.
A huge year.
Specifically, the International AIDS Conference in Vancouver in 1996. This is the year the narrative of this disease permanently, fundamentally shifts. This is the advent of combination antiretroviral therapy, often referred to as HAART, highly active antiretroviral therapy.
Okay, what was the mathematical and biological genius behind HAART? Why did combination therapy work where monotherapy failed so badly?
It comes down to the brutal mathematics of probability. Scientists realize that hitting the virus with one drug inevitably leads to resistance. But what happens if you hit the virus with 3 completely different drugs, targeting completely different stages of the viral life cycle, all at the exact same time? For example, you use 2 drugs that act as fake building blocks, and a third drug, a brand new class introduced in 1996 called a protease inhibitor, which acts like chemical scissors, preventing the virus from cutting its newly minted proteins into functional shapes.
So you're attacking the factory floor, the vault, and the shipping department all at once.
Exactly. And the math changes everything. The chance of the virus randomly mutating to become resistant to one drug is high. The chance of it mutating to resist 2 drugs is much lower.
Right.
But the mathematical probability of a single viral particle simultaneously developing the exact 3 independent complex mutations needed to evade all 3 different drugs at the exact same moment, it is vanishingly small. Trillions to 1.
It traps the virus. It pins it down from multiple directions so it cannot move, cannot replicate, and cannot mutate. So what does this all mean? Moving from the math to the hospitals, what did this actually look like on the ground for the doctors and the patients?
It looked like a miracle. And I really don't use that word lightly. The clinical sources and the oral histories describing the shift in 1996 and 1997 use language that sounds almost biblical.
Really?
Medical professionals often refer to it as the Lazarus effect. Imagine you are a doctor who has spent 15 years doing nothing but writing death certificates. Suddenly, you prescribe this new 3-drug cocktail. Almost overnight, in places that could access these drugs, the AIDS wards literally emptied.
You're talking about patients who are weeks away from dying, right? People who had already drafted their wills, said goodbye to their families, planned their funerals.
Yes, patients with practically 0 T cells left, wasting away from opportunistic infections. They started taking the combination therapy, and within weeks, the viral replication stopped.
Wow.
Their immune system slowly began to rebuild themselves. They started gaining weight. The opportunistic infections cleared up. They got out of their hospital beds, walked out at the front doors, and literally went back to work.
That gives me chills.
A universally fatal, terrifying diagnosis had been transformed through the sheer force of science and activism into a manageable, chronic, survivable condition.
It has to be considered one of the single greatest, most rapid achievements in the history of medical science.
Without a doubt.
But, of course, the incredibly sobering caveat you mentioned is in places that could access these drugs. Because these new combinations were, and in many cases still are, incredibly expensive and logistically complex to manufacture and distribute.
Yes, that's a massive issue.
We are going to address that massive global disparity in a moment. But before we look abroad, we need to trace how the science kept evolving here. Because the goal of public health wasn't just to keep infected people alive. The ultimate goal was to stop the virus from spreading at all.
Right.
We moved from the treatment revolution of 1996 to the prevention revolution of the 2010s.
Which represents another massive paradigm shift. Because scientists realized that if you can use drugs to deeply suppress the virus in the body, you fundamentally change the landscape of transmission. The first massive leap in this new era of biochemical prevention arrived in 2012, when the FDA approved the use of a drug called Truvada for pre-AP, pre-exposure prophylaxis.
This is a wild concept if you think about where we started this story with that 2-page MMWR report in 1981.
It really is.
We have gone from an unnamed, invisible, uniformly fatal killer to a daily pill that an uninfected person can take to prevent themselves from ever catching it in the first place. How does pre-AP actually work chemically? How do you treat an infection that hasn't even happened yet?
It works by preemptively building a chemical wall before the invader even arrives. Truvada contains 2 of those fake building block antiretroviral drugs we talked about earlier.
Okay.
When an HIV-negative person takes the pill daily, those drugs build up to protective levels in their blood and mucosal tissues. If they are subsequently exposed to HIV through sex, the virus enters the body and immediately tries to infect a cell and replicate. But the very first building block the virus grabs to copy its DNA is the fake drug block that is already waiting there. The replication chain terminates instantly. The virus dies out before it can ever establish a foothold in the body.
It puts the absolute power of prevention directly into the hands of the individual.
Yeah, it does.
For decades, prevention meant relying on your partner's honesty or relying entirely on barrier methods. Now, you have an invisible biological shield, but we need to be incredibly rigorous about the science here. What are the constraints of PEP?
The clinical constraints are vital to understand. The science is definitive. PEP is highly effective. Studies show it is over 99% effective at preventing HIV transmission through sex, but it strictly requires adherence.
You have to take it.
It is not a vaccine. It does not teach your immune system to fight the virus permanently. It requires behavioral consistency to maintain the biological shield. You have to take the pill daily, or exactly as prescribed by a doctor, to ensure the drug levels in your tissues remain high enough to block the virus.
Right.
If you stop taking the pill, the drug washes out of your system and the shield drops completely.
So it's an incredible tool, but it requires access to the medication and disciplined adherence. But then just 4 years later, in 2016, we get what might be the most psychologically profound scientific consensus of the entire 40-year epidemic.
Oh, absolutely.
It is the crystallization of a concept known simply as U equals U. Undetectable equals untransmittable.
This was the culmination of massive, rigorous, multi-year epidemiological studies, specifically the partner studies, which involved thousands of couples across multiple countries where one partner was HIV positive and the other was HIV negative.
What were they looking for?
What the scientists tracked were tens of thousands of instances of sexual intercourse without condoms. And the data proved something revolutionary. It proved definitively that a person living with HIV who is taking effective antiretroviral combination therapy every day and whose viral load is deeply suppressed to undetectable levels in their blood cannot sexually transmit the virus to a partner.
And when we say cannot, we need to be precise. We aren't saying the risk is highly reduced or statistically unlikely.
No, we are saying the risk is scientifically, biologically zero. When the virus is suppressed by the drugs, it cannot replicate enough to be present in infectious quantities in the bodily fluids.
The profound psychological relief that this scientific consensus brought to the daily lives of people living with HIV is almost impossible to overstate.
It changed everything for them.
Think about it. For 35 years, since the early 1980s, to be diagnosed as HIV positive was to carry an agonizing psychological burden. You were told that you were a permanent biological danger to the people you loved most. You were a vector of disease.
Yeah.
And suddenly, in 2016, science rigorously and totally removes that stigma. It proved that if you are on treatment, you are safe. Treatment fundamentally became the ultimate form of prevention. If you can test everyone and get everyone who is positive onto treatment, the virus starts spreading globally, period.
It is a complete and utter paradigm shift. The epidemic could, theoretically, be ended with the biochemical tools we currently possess right now.
Theoretically.
But as we touched on earlier, that theoretical victory relies entirely on access and distribution, which forces us to look beyond the borders of the United States.
Right.
Because while the hospital wards were miraculously emptying out in New York and San Francisco in the late 1990s and early 2000s, the epidemic was absolutely ravaging the global south. It was devastating sub-Saharan Africa.
Because they couldn't get the drugs.
The life-saving drugs existed, but they were trapped behind patent walls and prohibitive pricing, failing to reach the people who needed the most.
And this brings us to the final massive chapter of our deep dive, the global triumph and the looming threat facing it today. In 2003, the United States government launched the largest financial and logistical commitment by any nation to combat a single disease internationally in human history.
PEPFAR.
Yes. It's an initiative called PEPFAR, the President's Emergency Plan for AIDS Relief.
Launched under the George W. Bush administration, PEPFAR is a staggering display of structural, financial, and public health power.
It's massive.
We are talking about a multi-billion-dollar, continent-spanning program. It was designed to bypass the traditional bureaucratic hurdles and directly deliver rapid HIV testing, prevention services, and crucially consistent daily antiretroviral treatment to millions of people across low- and middle-income countries, predominantly in sub-Saharan Africa.
The sheer scale of what PEPFAR has accomplished is almost hard to comprehend. When public health officials talk about America's greatest global health achievement, this is exactly what they're pointing to.
Yes.
The metrics compiled in our sources credit PEPFAR with saving tens of millions of lives. Let that number really sit with you for a second. Tens of millions of human beings who would have inevitably died of a brutal disease were instead given the exact same chronic, manageable, survivable life that the activists in the U.S. fought so fiercely for in the 1990s.
It's incredible.
We are talking about whole generations of children who were not orphaned, entire national economies that were stabilized because their working-age populations weren't decimated. It is a staggering humanitarian triumph.
It truly represents the American federal health role at its absolute best, its most generous and its most unambiguous. The U.S. took the complex science developed in the academic laboratories and the pharmaceutical companies and applied the massive, unparalleled logistical and financial weight of the federal government to build supply chains and distribute generic versions of those drugs across the globe.
But history isn't static, and neither is the funding that sustains these massive programs. And we must solemnly note the present-day reality here, looking strictly at the documented facts and the data from our 2025 sources.
Right.
Again, we aren't predicting outcomes or taking political sides regarding federal policies. We are just relaying the current situation.
Right.
Right now, in 2025, PEPFAR's funding has become deeply contested and severely curtailed. This is happening amid a much broader, sweeping federal review of all foreign aid programs. And as a direct result of this ongoing review, a tremendously large share of the money that was previously appropriated by Congress for PEPFAR has been left unspent.
And looking at this purely through the lens of epidemiological science, the public health implications of this paused funding are stark and immediate. The biological rules of HIV haven't changed since 1996.
Right, the virus is still the same.
When funding for antiretroviral distribution is curtailed, supply chains break down, and the immediate risk is interrupted treatment for millions of patients. And as we learned from the early days of AZT monotherapy, if you interrupt a patient's combination therapy, if they take the drugs intermittently because of supply shortages, the suppressed virus immediately rebounds.
It comes right back.
It begins replicating again, it mutates, it develops resistance to the drugs, and it begins transmitting. If PEPFAR falters, you risk breeding drug-resistant strains of HIV on a continental scale. The program that embodied the absolute best of our global health capacity now stands under direct, immediate threat.
It is a profound, sobering reality to grapple with, especially considering how hard-fought the victories over this virus have been. Okay, let's zoom out and revisit the core thesis of this entire deep dive. We've taken you on an incredible 40-year journey today.
We really have.
We started back in 1981 with that quiet, 2-page surveillance report from the CDC about 5 young men in Los Angeles, the era of silent fear and terrifying official neglect. We moved through the brilliant, ego-driven scientific disputes in the laboratories of France and the U.S. to name the retrovirus and secure the blood supply.
We saw the lonely, astonishing moral defiance of Surgeon General Koop, bypassing his own administration to mail the explicit truth to 107 million American homes. We witnessed the raw, educated fury of ACTUP storming the regulatory gates of the FDA, permanently changing the way patients interact with medical research.
We tracked the agonizing biological milestones, from the toxic, failing hope of early AZT treatments to the mathematical brilliance and the Lazarus effect of combination therapy in 1996. We explored the prevention revolution of pre-P's chemical shielding and the profound psychological liberation of U equals U.
Yeah.
And finally, we looked at the massive global generosity of PEPFAR, which successfully brought the cure to tens of millions, but which is now facing such uncertain headwinds in 2025.
What this entire historical arc reveals is the ultimate split screen of the federal health role we discussed at the very beginning. When you look at the whole picture, the government was heroic in its core, design competencies, the CDC surveillance system perfectly identifying the anomaly, and Surgeon General Koop's defiant use of the bully pulpit for mass education.
Right, the things they were built to do.
But the actual machinery of salvation, the accelerated drug approvals, the chemical cures, the prevention tools, those were not spontaneously generated by the system. They had to be dragged into existence by outside forces. It took academic scientists, pharmaceutical innovation, and above all, furious, brilliant patient activists demanding to be heard.
Exactly.
PEPFAR was the rare, beautiful moment that straddled both sides of that screen. The government using its massive structural power to systematically distribute the cure that outside forces had fought so hard to find.
It's a complex, messy, beautifully human story of survival against unimaginable odds, and it leaves us with something credible to think about as we close. When I first looked at all these sources, I realized how much we all desire the clean precision of an X-ray in medicine. We want a clear diagnosis, a visible problem, and a system that automatically fixes it.
We all want that.
But the story of HIV showed us that when the diagnostic waters are murky and when the system's X-ray machine fails to see the fire, the system doesn't magically fix itself from the inside. It relies on relentless pressure from the outside. So, looking at the immense public health challenges we face today, whether it's the ongoing mysteries of long COVID, the looming threat of antimicrobial resistance, or the next unnamed pathogen waiting to be a two-page anomaly in tomorrow's CDC report, who are the activists currently standing outside the heavy doors of our medical institutions demanding to be let in? And what life-saving breakthroughs are we missing by keeping them waiting in the lobby? Thank you so much for joining us on this deep dive. Keep questioning the system, keep looking for the truth, and we'll see you next time.